Hello everyone, today we'll be talking about how to optimize FiO2 on the ventilator. FiO2 stands for fraction of inspired oxygen. While breathing room air, your FiO2 is 20%, or if you take the percentage point out, it's 0.2. So how much FiO2 should you start with? You always start with 100%, and the reason for this is after the intubation, there can be unrecognized issues such as tube in a wrong position, maybe the pulse ox is off, maybe the patient is hemodynamically unstable. So you always start with 100%. Once the things settle in, you titrate down the FiO2 to target oxygen sats of 90 to 94%. So let's talk a little bit about hyperoxia and its deleterious effects. In the lungs, it can cause damage to the pulmonary epithelium, it can inactivate the surfactant and cause edema. People who have been given 100% oxygen complain about pleuritic chest pain, substernal heaviness, coughing, dyspnea. Hyperoxia can also have deleterious neurological effects as well. The first symptom that occurs in patients breathing 100% oxygen is twitching of perioral and small muscles of hands. They also report tinnitus, dysphoria, nausea. Hyperoxia can cause seizures in up to 0.6% of the patients. At the cellular level, it causes influx of calcium and increased permeability of the cell, resulting in cellular swelling. Hyperoxia results in reactive oxygen species, which cause lipid peroxidation, protein oxidation, and DNA damage. And in cardiovascular system, it can decrease the nitric oxide production and increase prostacyclin and endothelin levels. So what are the problems with 100% oxygen in the lungs? In the lungs can result in oxygen toxicity due to reactive oxygen species, and that can cause oxygen-induced lung injury. It can also result in absorption atelectasis, accentuation of hypercapnia, and increased FiO2 mismatch. There are many reactions that cause generation of reactive oxygen species when you give somebody 100% oxygen. It can result in formation of superoxide radical. Your body has got defenses to deal with superoxide using superoxide dismutase, which converts into hydrogen peroxide, and hydrogen peroxide can further degrade it into water using catalase. Another important defense mechanism is glutathione and glutathione peroxidase, which can convert hydrogen peroxide into water by using 1 NADPH molecule to bring it back into its reduced state. Other non-enzymatic oxidants such as vitamin C and vitamin E are also very important in taking care of reactive oxygen species. In the lungs, intracellular oxygen radical can result in damage to the epithelial layers and also endothelial damage. They can also result in macrophage recruitment and release of oxygen-free radicals, and these can further lead to more destruction of the lung parenchyma, resulting in edema and subsequent death. So let's understand about absorptive atelectasis that happens when you give 100% oxygen. If you look at this figure, there are two alveoli. This one is getting 100% oxygen and this one is only getting 20%. When you give these patient 100% oxygen, absorption follows Henry's law, which states that the diffusion of gases happens according to the pressure gradient. And you can see in the alveoli with 100% oxygen, the pressure gradient is much higher than the one getting 20% oxygen. So reducing the nitrogen from giving these patients 100% oxygen, you remove the nitrogen from this alveoli, and nitrogen is the one which stabilizes alveoli and prevents it to become atelectatic. High oxygen can also accentuate hypercapnia by Haldane effect. Haldane effect is nothing but increased capacity of blood to carry CO2 when the hemoglobin is in its deoxy state. So if you look at this graph, we have got partial pressures of CO2 and we have got CO2 content, and the CO2 carrying capacity by oxyhemoglobin with sats of 100% is the difference denoted by this red arrow. However, in a deoxy state, the carrying capacity of hemoglobin for carbon dioxide is much higher. If you give these patients higher FiO2, it can result in lower carrying capacity of carbon dioxide, and the remaining carbon dioxide will transfer dissolved in the blood, which increases your PaCO2. Increased FiO2 also results in FiO2 mismatch. So looking at this figure, we have got three different alveoli. There are two normal alveoli with FiO2 of 100 and FiO2 of 40, and with a good oxygen and CO2 exchange. And we have a poorly functioning alveoli. Your body would cause hypoxic vasoconstriction to the alveoli which is non-functional, thus diverting the blood flow to the healthier alveoli. As the FiO2 increases, you can see that the hypoxic vasoconstriction is lost, resulting in increased shunting. It also results in removal of blood flow from the normal alveoli, resulting in relative dead space. It can also cause atelectasis and reduce oxygen and carbon dioxide exchange. And as the FiO2 increases, you can see that the shunt has gotten worse. We have more relative dead space and we have more atelectatic alveoli, and atelectatic alveoli also results in shunting. So we have worsening VQ mismatch all the way around. Whenever you're calculating the PF ratios, remember to reduce the FiO2 to target sats of 90 to 94%. PF ratio is commonly used in describing ARDS and its severity, and it is the ratio of partial pressures of oxygen and FiO2. In case of shunts, the PO2 doesn't change significantly with FiO2. So let's take an example. In this case, a patient with 20% shunt at FiO2 of 0.9, his PO2 is around 140, which gives you PF ratio of 155. If you reduce the FiO2 to 40%, the PO2 is now 80 and PF ratio now is 200. Thus, the real PF ratio of this patient is 200 and not 155. The multiple papers that have studied target sats between 90 to 94% and traditional, which is conventional, between 96 to 100%. This is one of the good systemic review and meta-analysis which has looked into multiple RCTs and patients with critical illnesses, and they found that the patient who were targeted for a liberal strategy with SATs of 96%, range 94 to 99%, had increased mortality with relative risk of 1.21, which gives you increased mortality by 20%. Thus, in acutely ill patient, liberal oxygen therapy might become unfavorable above a SpO2 range of 94 to 96%. So make sure that you titrate your FiO2 down. I would recommend reading this article published in British Medical Journal, which talks about clinical practice guidelines for oxygen therapy. And they recommend for acutely ill medical patients, that is the ICU patient, to target the SATs lower than 96% and not starting oxygen therapy if your SATs are between 96 to 100%. So before giving any oxygen, always assess the risk and benefits. The reason you are giving oxygen is to correct the tissue hypoxia, so that is the primary goal of oxygen. If you give them too much oxygen, understand that it can result in oxygen-induced lung injury, absorptive atelectasis, and worsening VQ mismatch, which can actually result in oxygen exchange and worsening tissue hypoxia. The bottom line of optimizing FiO2 is you make sure that enough oxygen is delivered to the tissues and cell and not too much. So once you intubate your patient, start at 100% and then taper down the FiO2 to target SATs of 90 to 94%. Always attempt to come down to 60 to 70% to reduce oxygen-induced lung issues. However, there are certain exceptions for targeting higher FiO2s, and these include carbon monoxide poisoning, sickle cell crisis. We also use higher FiO2 in patients with pneumothorax, pneumomediastinum, and air embolism, where it increases the reabsorption of these air cavities, as we discussed before. It can also be given in cluster headaches as well. Thank you.